Let us go through a brief overview of the dose targets in peritoneal dialysis. Dose targets over the years for chronic peritoneal dialysis have been highly variable. Initially, it was simply a target for the urea levels or the creatinine levels. Subsequently, it became KT over V urea, a high target of at least 2.0, and later on it was titrated downwards to a KTV urea of at least 1.7. We'll go through a few studies on how this last value was derived. An important study is the Canosa study, which was published in 1996. It is a prospective cohort study with 680 consecutive patients, and it found that the lower the KT over V, the poorer the patient's survival is. It was the same for the creatinine clearance as well, and this led to the conclusion that the KT over V urea should be above 2.0 for all peritoneal dialysis patients. Subsequently, the Canosa study was reanalyzed by Joan Buckman and team, and it found that the main contributor was actually in the residual renal function. For every 5 liter per week increase in the glomerular filtration rate of the native kidneys, there was a 12% reduction in the relative risk of mortality. The peritoneal creatinine clearance actually showed no association with mortality. And if estimates of fluid removal was added to the Cox model, it was even more striking. For every 250 ml increase in the urine volume, there was a 36% reduction in relative risk of mortality. It was therefore concluded that the main determinant of PD survival is with the residual renal function. The next landmark study that came along was the ADAMEX study, published in 2002. This is a prospective randomized controlled trial conducted in Mexico with 965 patients followed for at least 2 years. The patients were randomized to either continue usual peritoneal dialysis, 4 times 2 liter exchanges, or to try to target a high-dose creatinine clearance of 60 liters per week. What was achieved in the control group, creatinine clearance of 46 liters per week, standardized KT over V urea of 1.62, versus the intervention arm with a higher creatinine clearance of 57 liters per week, and a KT over V urea of 2.13. If you see this survival curve over here, there was no difference in survival. The third study is the Hong Kong study, which was published in 2003. 320 new CAPD patients with a residual renal function of less than 1 were randomly assigned to 3 different groups: a KT over V urea of 1.5 to 1.7, 1.7 to 2.0, and more than 2.0. They did achieve good separation in terms of the peritoneal KT over V, but when you look at the cumulative survival, there were no differences. In the group with the KT over V urea of less than 1.7, they required more erythropoietin and had more uremic symptoms. The clearance targets were therefore lowered based on the data from the ADAMEX and the Hong Kong studies. Since 2005 and 2006, based on the available data, various organizations revised the target dose for standardized KT over V urea for chronic peritoneal dialysis, and the consensus is to target a minimum KT over V urea of 1.7 per week. It is important to note that the studies and guidelines target a delivered dose. However, delivered dose is quite often lower than the prescribed dose, and in practice, it may be necessary to prescribe a higher dose to prevent grossly inadequate small solute clearances. What is considered inadequate peritoneal dialysis? There was a NECOSET study published in 2005, a prospective observational study from the Netherlands, and they found in 130 anuric PD patients undergoing peritoneal dialysis, There was a significant increase in the relative risk of mortality with very low doses, KT/V urea of less than 1.5 per week. On the other hand, in the days when we were targeting a high peritoneal dialysis dose of more than 2.0, there was increased transfer to hemodialysis, higher volumes of peritoneal dialysis used, leading to increased cost and even complications such as hernia. There was also much higher glucose exposure, leading to weight gain, poor DM control, and possibly even more inflammation, atherosclerosis, as well as membrane failure. In summary, the evidence suggests that a minimum delivered KT/V urea of 1.7 is adequate for most patients. The target small solute clearance may still need to be individualized for some patients, and this recommendation focuses only on small solute clearance, and other clinical aspects of dialysis adequacy should not be neglected. Thank you.